Testing, testing. Does it work? So I think the session starts at 4:25, and maybe it's at the end of the meeting, so like there's less people. But do we want to make this more informal? Like I see 5 members of the audience. We can like sit in the front and just go over some cases. Do you want to do that? And we'll go over like some challenging CNS cases and just discuss kind of our thoughts. Because we made this into. Dr. Chan and I, we picked out some select cases, like cases that are somewhat complicated, and we can maybe go over thoughts and questions, or if you have cases you want to talk about, we can maybe like discuss together. Would that work for everyone? Okay. All right. So why don't we go ahead and get started then? I was asked to provide a couple difficult CNS cases, so I have a couple slides. Dr. Chan has a couple slides too. So yeah, if it's okay, I'll go ahead and do my presentations and go over some cases with you. So these are challenging, but they're not like exceptional. So I'm gonna see if I can move to the presentation. If you don't mind, thank you so much. Let me go back. So again, for those who don't, I'm Tony Wang. I'm a radiation oncologist at Columbia University. Welcome to the difficult cases section on CNS cancers. Disclosures are electronically available. So I'm gonna go over like there's more than 4 cases that I have. I'm gonna go over intact brain metastasis near critical structures, a postoperative brain metastasis case, acoustic neuroma case, and then like intact meningioma cases, for which I have like 3 kind of questions for you, okay? So the first case I have is a patient that has this is a 60-year-old gentleman with metastatic melanoma, vision's perfectly intact, and presents with an MRI scan looking like this. So there are 2 metastases, one in the left prechiasmatic space and the other located in the left temporal lobe. And I guess just for the general audience, if anyone wants to chime in and participate, how would you like to manage this patient with a melanoma with 2 brain mets? And then what's contoured there is the optic chiasm, right optic nerve, and left optic nerve is actually kind of pushed away. But this patient's visual field is intact. Anybody want to, I guess, I'm trying to make this informal, so like, anyone want to kind of give an idea of how you want to approach this case? So, no, okay. It's okay, whichever you prefer. Okay, no worries. Okay, I'll break the ice. So I guess maybe we'll just talk about it. So I guess for those who are familiar, not familiar with a case like these, like, for melanomas or any kind of brain mets, if they're a tumor that's really close to the optic apparatus, it's challenging because, on one hand, this patient presents with like limited brain metastases. I want to radiosurgery this. But on the other hand, I'm going to have some issues with dose constraints to this spot. So I think most would agree that this smaller left temporal lobe lesion is probably very amenable to radiosurgery. The question is, what do you do about this one? And so this is a gamma knife treatment plan, fortunately this patient has intact vision, so you want to make sure you don't want to cause radiation-induced optic neuropathy. So what I did with this case was using the icon, I framed the patient on day 1. I treated this left temporal lobe lesion to 20 gray in a single fraction. I think I did up to 22 gray. And then I wasn't able to achieve my dose constraints to the optic chiasm. So on that first day of frame, I just basically treated this using a 6x5 regimen. I couldn't even do 27 and 3 because I couldn't keep my optic chiasm and left optic nerve, which is completely blocked off by the left by this tumor there. And then I used the mask for this patient at day 2 and 5. Probably I repeated MRI scan at some point just to see if there's any adaptive changes to the tumor, and that's what I did with this case. And I kept the Dmax of the left optic nerve and the chiasm under 25 gray. So so this is the one case that I did. So any questions about? Again, there's no right way. It was just sort of my strategy in sort of treating a patient like this with a very difficult location. So feel free to chime in if you have any questions on this one. Okay. Oh, well, this one I didn't use the lin. I had a gamma knife. So it's so it wasn't a LINAC-based kind of radiosurgical treatment. So yeah, I didn't use LINAC, if what you mean. This was a gamma knife treatment plan for this. But I imagine a non-coplanar SRS technique, if you use a LINAC, probably would have been best for this, because I don't think you would have achieved good constraints and keep your optic chiasm conformally with a single, with a coplanar treatment plan. Yeah. Yeah.
How do you decide to use sixth grade for one fraction and followed by 24 grade?
Well, so I guess I should have said this. With the gamma knife immobilization, typically we had used a frame for a long time. So so what I did was on the first fraction, I treated this like as if I was treating a frame case, this spot, and then for this spot, I just treated it using a hypofractionation dose. And then on day fraction 2, this is already addressed, but I need to still do like therapeutic dose to this spot, right? So I decided to do like 6th grade times 5 regimen for this melanoma. I would have preferred a higher, like a 27-3 or 30-3. However, I wasn't able to achieve my dose constraint with 3 fractions on this because the tumor was abutting left optic nerve. So just a recent case, yeah. So that's why I did this fractionation. I would have done it in single fraction if I could. Yeah. So this patient actually responded beautifully, believe it or not, and it's very lucky. Vision's intact. Okay. I talked about postoperative brain metastasis in my session earlier this morning. This is a 50-year-old woman with ER-PR positive, HER2 negative breast cancer and presented with right-sided weakness. And the MRI showed this. So as you can see, there's a fairly large, sizable left frontal parietal heterogeneous enhancing mass with vasogenic edema and not much of a shift. So underwent surgical resection, and that's the postoperative MRI cavity. And the patient's right-sided weakness actually recovered somewhat. Anyone want to sort of chime in and tell me sort of what you'd like to do next step for this patient? Or take a stab? I mean, so this is the postoperative MRI scan with a pretty good GTR resection to my eye. Maybe some post-surgical changes at the periphery, but overall it looks like a pretty good near total gross total resection. So I don't know if you want, but so typically even for GTRs, as I was presenting earlier this morning, I typically do boost to these based on the Anita Mahajan phase 3 trial where you're boosting at your 12-month low control, it's better than just observation. So I just boosted this. And depending on the cavity size, my dose can change. But I typically will do 16, 18 gray depending on the volume. If it's even smaller, I'll do 20 gray to the cavity if possible. So what do you want to do? Dose. So I just did a single fraction because this was small enough. I didn't think it needed fractionated radiosurgery. And the 1-year control rate with post-op SRS for GTR, according to her phase 3 trial, was about 73%. So better than 42% in the observation arm at 12 months. So yeah, so exactly, I did. I followed the Alliance A071801 trial, which the volume of this tumor was, I think, a little under 4 cubic centimeters, so I was comfortable getting 18 gray to the cavity. I did a little margin around it, so I usually do like a 1 or 2 millimeter margin around the for post-op. I will do a little like a margin around the GTV, and then I keep my selectivity usually under 0.8 or higher if I can, and then my gradient index I try to keep under 3 at 3. Are you familiar with the indexes of gradient index come from it? Okay. Acoustic neuromas, I don't know how often you see them, but I see them quite a lot in my practice. So these are either known as visceral schwannomas. It's benign, typically arises from the Schwann cells from the 8th cranial nerve. Usually accounts for about 5 to 8% of intracranial tumors. most common presentation is hearing loss, followed by imbalance and tinnitus. Some patients can get trigeminal or facial dysfunction, unfortunately. And it's typically arising from the Obersteiner-Weidrich zone near the internal auditory canal meatus at the 7th, 8th nerve. So this is just an example of a representative slide where you have a very homogeneously enhancing mass. This is pretty sizable, pushing against the brainstem, and that's pretty kind of typical for acoustic neuroma, moderate size. Usually I see acoustic neuroma is a little smaller than this. This is fairly sizable. So for these, I typically give about 12 gray. It depends on your platform. So I use the Gamma Knife. We usually use 50% isodose lines, and for coverage, I really try to go 100%. But sometimes if a patient has a hearing intact, and I can't keep I usually try to keep my cochlear dose at either Dmax of 4 or mean dose of 4 gray. This is a patient with a intact hearing. If the patient has no hearing, I don't really constrain the cochlea because you're not really protecting anything. And I keep the mean dose under 4 gray if I could, but typically I keep my Dmax under 4 gray. And then for my brainstem, I like to keep my V10 under 0.35 and V12 under 0.1 cc's if possible. And for my selectivity, I usually aim for 0.8 gray, 0.8 or higher if possible. And it's fairly easy to do that with the Lightning treatment planning system. So for these, and I'm just focusing a little more on this because this is a little more unusual, but I usually contour on my T1 and contrast imaging. The T2 helps with both the cochlear contours, but also verifying that your target volume for your acoustics is actually right on point. And these are overlaid. And then the OERs are typically my cochlea. So that's the cochlea right there. I call it a flying saucer. My ENT calls it a sombrero. But that's basically the small little spot, and that the modulus is the centerpiece right between that area. And depending on your acoustic neuroma, I also contour the brainstem for sure and try to keep it under at least a 10 gray max dose if possible. Just some sample plans, like these are, again, GK plans where I basically have, for Gamma Knife, I keep my isodose at 50% or less, or higher if possible. I do really small shots at 4mm collimators if I could, and I try to put my shots away from the cochlea. So this is like a 4 gray isodose line. The green line is the 4 gray. The yellow line is the 12 gray isodose. You can see I kind of bended the plan off the right cochlea here to minimize dose to the cochlea, which is associated with hearing loss, dose dependent. So that's the fractionation or prescription dose that I usually use. And then the selectivity is usually at 0.8 or higher. This is just another plan where, again, this patient has very intact hearing. I was able to, prescribe. This is a patient with right acoustic neuroma, where I can prescribe 100% to 12 gray, or I'll try to keep a minimum 98% coverage with a high conformality index. This is the dose of the brain. So you can see it's kind of abutting the brainstem at the level of the midbrain. And this is the brainstem DVH at 12 gray. It's basically undetectable. The max dose really was really well achievable with the Gamma Knife. As is with any other platforms, it's fine. But I would, you can keep a really good dose conformality with these cisternal acoustic neuromas. This is just another example where this is probably a little harder. This patient has a very moderate size acoustic neuroma, but unfortunately the distal end of the acoustic neuroma is really pushing into the intra-auditory canal, past through the meatus, and likely really into the cochlea with a intact hearing. So for these, I try to keep my max cochlear dose under 4 gray. This is very difficult to achieve because if you want to prescribe this 12 gray, I don't think it's almost even possible. For the brainstem constraint, it's not an issue, but when you try to treat this whole area with 12 gray, it's hard to keep 4 gray isodose lines. So you have to really sector block your Gamma Knife plans. And again, with Linac-based, I imagine you'd have to do non-coplanar beams to do that, to achieve that if possible. But these are very tight margins, so you have to have a really good small MLC collimators to do your treatment plans. Otherwise, I don't think this is very achievable with some Linacs out there. So I'm going to move on to, in terms of outcomes with these acoustic neuromas, so generally with either Gamma Knife or linear accelerator single fraction radiosurgeries, the Tumor control rates are usually about 90%. It's pretty decent, but the biggest issue is hearing preservation. That really varies from 40%, 90% loss, 40 to 92% hearing preservation. Excuse me. So for my, I think I have 3 questions or 3 cases for these. I have 3 meningioma cases, and again, I just had a smattering of like cavernous sinus meningiomas like back to back last week. So this is these are my 3 kind of questions. I'll just kind of go over. First case, this is a 73-year-old man, with an interval enlarging meningioma. It's been monitored for some time. It's near the left optic nerve. This is the left optic nerve right there that's been contoured. And this enhancing T1 gadolinium mass is located at that spot. And right now the patient is asymptomatic 73. Like, I guess, how would you want to approach this case? You know, do you want to do no radiation, single fraction radiosurgery, fractionated radiosurgery, conventional fraction external beam, or others? And do you want anyone to take a stab at it in terms of how you want to approach this case? There's an audience interactive question. If I don't know if you know, if this is one of the questions I think for interaction. Is there able to do that? Okay. Anyone want to take a stab at it? This is the interactive question, the first one, I think. Just to recap, a 73-year-old man with a interval enlarging left cavernous meningioma. The tumor is fairly close to optic nerve. How do you want to treat this? Okay, fraction radiosurgery. Yeah, and there's no right answer. It's just sort of your preference. I've been comfortable treating these with SRS, single frac, as long as I keep my optic nerve dose under 8 gray. Or I can go up to 10 gray. I'm a little more conservative. I try to keep a Dmax under 8 gray if I can. But if it goes above 8 gray or below 10 gray, I'm still okay with it, because the risk of optic neuropathy is still under like 1% or less, according to high tech. So, okay, great. So if you don't mind, I'm going to my next case. All right, so this is another one. Okay, now this is a 58-year-old woman, asymptomatic, no symptoms whatsoever, but also been watching an interval enlarging meningioma, or presumed meningioma radiographically. Same answer choices. You know, how would you want to approach this case? Okay. So would you mind going over the interactive questions? Okay. So answers are, you could not treat, simplified radiosurgery, fraction SRS, conventional fraction external beam radiotherapy, or others. Okay, all right, so same thing, no difference. You treat it the same as you would. Yeah, I get it. Yes, everyone's very different about that approach. So, yeah, I think both are reasonable. You know, that's clearly a lot larger tumor than the one before that. There are some I know who actually are still very comfortable treating single fraction radiosurgery. And then for fraction SRS, I don't know what doses you typically do for those that answer that, but like, if I was to do that, my treatment for that would be like a 25 and 5. And keep my brainstem under 22.5 or 25 gray, D.03 cc's. And then for conventional fraction external beam radiotherapy, you know, I think most would do like 50.4 to 54. Some even do 52.2. I've done that before too. Yeah. So okay. So and this is my last case. I think we're moving on really quickly. The next. Okay. Just to make it even more challenging, I saw these back to back. It just get larger and larger. And I said I'd stop my clinic that day. No more. So then this 68-year-old, I misspelled it, woman with a symptomatic interval enlarging meningioma. That's your MRI scan. It's almost like the same patient, but they're really not. And same answers. So yeah, tell me please let me know what you do with that. So can we do an interactive response? Thank you. So same answer choices. Oh, interesting. Oh, okay. So I guess most chose the fractionated radiosurgery and less external beam radiation therapy. I'm curious. Okay. Okay. Let's go. So let's go back to that slide. So the yeah, I'm surprised just because I thought more would kind of be more comfortable doing fraction external beam, which is fine. I think you probably can still do 25 and 5 on this. And actually, yeah, that's very true. Especially for patients that are maybe older and just can't come for 6 weeks of radiation therapy. I think 5 times 5 is kind of the way to go. There's a phase 2 trial that just came out from the Italians, the January of this year's issue. It was phase 2, 5 times 5 for large or large meningiomas greater than 3 centimeters, or they were within 5 millimeters of a close OAR. And there was a 97% control rate at, I think it was 3 years or 5 years. And the sample size was like 100 patients or something like that. I thought that was pretty convincing for me. So yeah, I mean, I agree. I mean, I guess he's a 25 and 5. I'm a little scared, but I guess that's okay. So I think that's it with my, and if you have any questions, please feel free to email me. If any, love to hear your thoughts. So I'm going to pass on to Dr. Chan. Okay.
Yeah. Mine's going to be very short, just a couple cases, a little bit weird ones. Okay, so in line with what I was talking about with radiation, these were some cases that we had in clinic, and see what you think here. So this was a while ago, all right? Which is why we use whole brain radiation. It's probably over 10, 12 years ago. This is a patient. It was a 64-year-old woman. Came in with metastatic melanoma in the bones, lungs, and brain. The brain disease had 3 brain metastases. At the time, this patient was actually treated with the whole brain radiation therapy. Nowadays, our threshold for whole brain is actually a lot more, but at the time, it was standard of care. You can easily, apply this for radiosurgery as well. And A was the MRI before. Actually, how do you?
That button, yeah, the middle button.
The middle button?
Yeah.
Oh, it did not.
Oh.
Huh. This one?
That
No.
is like a laser pointer. This
I need a laser pointer.
Yeah, yeah, there you go.
Oh, where is it?
You see that?
Oh, yeah, there it is.
It's not really.
Oh, fantastic. Okay, so this one was actually before treatment. And this patient was on IPI the whole time, okay? And, widely metastatic disease, so we didn't really want to take her off. And then this was the MRI that was obtained about 2 weeks after the end of whole brain radiation therapy. So, the radiographic report on the MRI was actually concerning for hemorrhage, okay? And I don't know if you see this actually in clinic a lot, but we actually see this quite a bit. And it's very easy to say, oh my gosh, this is bleeding, this is or progressing, right? So what do you do? Do you send patient immediately to the OR for resection, retreat lesions, or do you wait and monitor? Do I have to do anything here? Okay. Okay. All right. Well, those are all good thoughts. This is what we. Ooh. Yeah. that's what we used to do, treat lesions immediately, but we no longer did that, largely because we realized that many times these things are just immune reactions, actually. So we actually do nothing, and it just treats symptomatically, and we actually we'll wait and monitor now. So, and that's been a very big change compared to what we used to do before immunotherapy came on. And so many patients, especially in lung cancer and in melanoma and renal cell carcinomas, are actually on immunotherapies now. That we see this all the time. So this is a real change in our practice that we do now. So anyway, 4 months later, I put actually up here, the 4-month scan later on. When the lesions were actually just as big. But what happens is the whole thing actually subsides. This is a brain PET that actually showed that even initially there was like very little activity before. So, and there are like resection series that actually show that these things are all immunologic reactions. And I don't know what your radiology reads, but do they call it hemorrhage or do they call it edema? I'm not sure. Like, what do your radiologists call it? Ours calls it hemorrhage, just for a lack of description of this. It's not really a hemorrhage, right? It's just more contrast enhancement, in the brain. So I'm just curious, have you come across this, and what do your radiologists call it? Hopefully more intelligent than what our radiologist calls it. But it's really not a hemorrhage, okay? It's very rare that it really is a bleeding out. And if you just monitor it, you'll see that it plateaus out. Okay, so here we go. This is another case, a brain metastasis to be treated with SRS, but patient is on anti-PD-1. So 59-year-old with metastatic non-small cell lung cancer, EGFR wild type, who is getting a single agent pembrolizumab, and he develops one brain metastasis. Okay? All right, what do you do? Take the patient off anti-PD-1 and then treat with SRS. Take patient off anti-PD-1, treat with dexamethasone, and then treat with SRS. Treat SRS concurrently with anti-PD-1, or send patient for resection. All right, let's try that. All right, yes, 100%. That's what I would do too. Yeah, everybody does that now. So, all right, and this is what essentially happened. I showed this in my lecture, of course. We treated this to 21 gray, and this thing blew up. Everybody freaked out, but eventually it just goes away. So no worries. You don't have to do anything. All right, and so just a couple slides here. SRS for brain metastases is safe to give concurrently with anti-PD-1, anti-CTLA-4. Pseudoprogression is very common. It can occur up to 50% of lesions, and it may look like a limited bleed, but it's really not. The radionecrosis rate may be a little bit higher, right? But it's hard to distinguish from pseudoprogression, and this can be treated symptomatically. Don't need to take these patients to the OR, really don't need to retreat or anything. This is really kind of up for grabs. I mean, these numbers are based basically on small numbers, single institution series, many of them, in different parts of the world, different dosing schemes. But in general, we think that, these numbers are about right. And I showed this before, but there is an indication that actually, if you do this concurrently, it seems like in multiple studies, phase 1, phase 2 studies, retrospective studies, that you're actually deepening the response. You're actually getting more of whatever it is that we see to clear away on SRS. And it seems like it trends more with better local control, but really, the data is still out there. These are definitely not randomized trials, but it looks, in my mind, I'll tell patients there is some data which shows that doing it together actually is better. Okay, that's it for me.
So I guess this is a small group, and if there are any cases or they want to go over, this would be great. We're happy to provide opinions. Does anyone have any cases or questions they have?
Does everybody here treat CNS? Is it very busy in Taiwan, or where are most of the CNS treated? Is it at the big centers or spread out?
Right now, I'm focusing on gynecological oncology. So,
Oh.
I don't have so many experience about the CNS cancer. So, yeah, I have a great interest to these cases today. Yeah, thank you.
Thank you too for your kind talk, and I would like to ask, how could we differentiate the true lesion after the SRS or radio necrosis, and any comment on the re-irradiation, repeat SRS, and what's your suggestion about the dose, the fraction or the time interval between repeat re-irradiation, but we have to first confirm it is a true disease or it's a benign phenomenon.
Just to clarify, this is brain metastases, right?
Yes.
So I guess I can speak first. So oftentimes radionecrosis is not very easy to determine, right, on just MRI scans. So we, and every institution is slightly different. I would say, if we have questions and the first MRI shows suggestion of a treatment effect or pseudoprogression, tumor progression, and there's an actual clinical question to be answered, like that has to be addressed in terms of the patient's symptomatic status from that. If it's asymptomatic, I don't know how aggressive it will be, but what we've typically done, and there's some exceptions to this rule, is we may get MRI spectroscopy or PET brain scan. Again, that's not 100% by any means, and I think we're overall fairly conservative, especially if it's something that's been SRS within the first 3 to 6 months. Obviously, if there's, I'm sure Dr. Chan's seen this too. Like you might have an MRI scan looks great, and then at 12 months or 15 months, you might have MRI that starts looking a little worrisome, and so that's where we also repeat MRI scans, and also if it's surgically resectable or biopsy, we might actually do that too, depending on the symptoms.
Yeah, I'm actually interested to hear what you guys do. We have, in the past, much more use of brain PET, which I showed you, right? Which is not available at many institutions. It takes special imaging windowing and everything. So, some places have that. Diffusion actually is reasonable, but more likely, more and more institutions are using perfusion now, right? So it's a combination of perfusion and diffusion with more weight put on diffusion. Really comes from a lot of the stroke literature, So if you weight it, so now at Cleveland Clinic and also at Memorial, we both ran perfusions, and perfusion is basically weighted and timed so that blood flow you can see the the flow through that area, and generally that's from various studies it's anywhere between 40 to 75% accurate positive predictive value. I mean, it's still not great in my experience, right? So most of the time it's just time, like, you watch it a little bit. And so we have all these patients that are like, we watch a little bit and hopefully it'll get better, but sometimes it gets worse. So what do you do? I'm curious.
And just like you just suggest, if the patient is asymptomatic and maybe the other side of the body is still under control, maybe close follow-up, active surveillance is more preferred in our practice, especially when we just finish our SRS treatment like 3 months, 6 months, but with the time goes by, and if the lesion is more suspicious, or the patient becomes symptomatic, or the new lesions develop, maybe we could discuss with the patient about the repeat treatment. But the modality of repeat treatment, like the radiation, or refer him to the surgeon, or other systemic treatment, is an open question, and we could discuss with the patient.
Yeah. Are surgeons here aggressive in operating or not?
It depends. It just maybe some younger, more aggressive neurosurgeon would like to maybe just get some tissue, because that maybe the gold standard to differentiate the true lesion or just necrosis. But I've already heard some hospital have some laser interstitial surgery technique, both to diagnosis and to treatment the necrosis or the recurrence.
Any other questions? Or cases or other practical?
Yeah, actually, I'm very curious. So in CNS practice here, is it divided into specialty, or does, like, you're a gynecologic radiation oncologist?
In our institution, we have a specialty to treat radiation oncology, to focusing on CNS in our institution. But it depends on every different institution have different situation. Yeah, so yeah, my colleague is better than here. But I'm interested to the case of Professor Wang. Yeah, the meningioma. I favor conventional fractionated dose. Yeah, because there is a bulky, yeah, and the closed organ at risk. So, but I like to ask a question: how to define the meningioma of the case 4? Yeah, because I see a tail on the meningioma. So
yeah, I think you'll hear different opinions. I have not really routinely chased dural tail as much, but like sometimes the question is, at what point do you stop? So I've used T2s to help me. I think the T2s are very accurate. T1 enhancing meningiomas sometimes, in my experience, has sometimes over-contoured a little bit, versus like true meningioma where, so I definitely fuse all the MRI sequences that are helpful for me for contouring. I don't necessarily chase, like I said, dural tail. Like for SRS, I don't routinely chase a dural tail. It's just not really been my practice. I'm sure there are some people who do, and I'm pretty sure there's some papers out there just that question. But yeah, so I don't routinely chase it. I think and the same goes for fractional external beam. I don't necessarily chase a dural tail. Yeah.
Thank you.
Yeah.
Yep.
Yeah, it's not really. I don't answer that.
Yeah, he has a question about memantin. Yeah.
Oh, sure.
It seems that you do more SIS than whole brain irradiation. But if the patient needs whole brain irradiation and the hippocampal sparing is possible, what's your experience about prescribing memantin?
Oh, yeah. So I'll mention the whole brain. So it's still used in the United States, but much, much less. So, I would say the threshold of using it, we routinely treat more than 10, 12, 13, 14 mets, depending on histology, right, and line of treatment. But if we treat, if it makes sense, patient has a pretty good performance status, we'll routinely prescribe memantin, actually, very commonly. And, actually, do you do that now? Do you do that here, or the government covers it, no problem?
No, it's self-pay.
Oh, yeah.
How much is it? Would you know?
Expensive.
Yeah.
Not very expensive.
No?
Oh,
Not
that's
very
good.
expensive.
Yeah, in the United States, it can be, like, pretty expensive. Yeah, yeah.
Maybe No, 500 NT
Per-
New Taiwan dollars
per
week.
per week.
Yes, per
Oh,
week.
that's not bad.
No, so it's so okay. 500 Taiwan NT for a week. So 2,000 a month.
We will use 24 weeks, right?
Yeah,
Twen-
for
20
approximately 6 months.
6 months.
Yeah.
Yeah.
6 months.
So yeah, but well, anyways, it sounds like it's a lot more affordable here than it is over there.
Yeah,
So
that's really great.
yeah, that's great.
Around 6 or 7,000 Taiwan dollars.
Yeah,
So the whole course is 6,000, right? It's still not super
Yeah.
cheap either, right? I mean,
yeah, it's
still-
not super cheap, but
Yeah,
I see.
that's great. You know, the one thing I'll add about meningiomas is that practice increasingly, I don't know about you, but is moving away from single fraction for meningioma because there's a lot of edema that can happen, especially if there's a pre-existing edema on the meningioma. So our practice in our brain tumor center is to no longer treat meningiomas that have a sign of edema already with single fraction. I personally have had over the number of years I've been in practice, a couple cases where, you know, a little tiny lesion just has blown up into this big swelling that's been terrible, right? And it's a small minority, but when it happens, it's like debilitating, you know. So I've actually begun to like use single fraction much less, you know. So yeah, I don't know what you do.
Yeah, I've been probably more in fractionated radius, like so 5 times 5 is, I've seen patients tolerate that far better. In fact, yeah, I don't, conventional external beam radiation, I actually prefer that for like the large ones, but I'll say like patients that I'm seeing, it's that threshold for them, convince them to come 5-6 weeks is getting, I think, harder and harder to convince them to do that. So I think the 5 times 5 is a pretty good compromise. Yeah. I've done this too, which I don't know if it's just, but like if it's so large, like the one I showed the last case, like I've even just compromised in 22.5 in 5. Like so it's like 4.5 gray, but then there's like a little bit of hot spot. If it's a really large patient, and it's like patients are coming from more ways, they just don't want to come for every day for 6 weeks. They've done that too. So, yeah. Yeah, I don't know. Are you hypofracking pretty much a lot more now in your practice here, or is it about the same? No. Yeah. Out of curiosity, how many of you are using LINAC-based radiosurgery for your brain tumors versus Gamma Knife or CyberKnife? Like, what are your platforms here? What do you use for brain radiation? The machines you use? Do you know? LINAC? Like a True Beam, or what kind of LINAC do you use? Electa? Okay. Are you as well? Are you using? Oh, you have a Zap. Oh, True Beam or LINAC. Okay.
We don't have CyberKnife in our institution, and the Gamma Knife only some institutions have a Gamma Knife.
Yeah.
Yeah.
Got it. That's good to know.
Great.
Yeah.
No, I don't change dose at all. And if the patient is asymptomatic, I don't do any Decadron. Because, even though there are studies that show that, that steroids really doesn't impact the ultimate outcome of immunotherapy, I don't know, you just gotta kind of feel funny about it, right? Because, steroids, right? So, unless the patient is very symptomatic, I don't actually prescribe Decadron. So, yeah. Of course, it depends on size, right? I mean, small lesions, don't do Decadron. If it's a big lesion, like, 2, 3 cm, and the patient wasn't on immunotherapy, then I'll give Decadron, as standard practice, right? But I'll try to withhold it, just kind of see if the patient's asymptomatic, how much edema there is, and decide on a case-by-case basis if the patient is already on an immunotherapy. I like to avoid it, if possible.
Yes.
Do we need to hold the immunotherapy when we want to prescribe the SRS, or no, not just keep the immunotherapy and we can do what we like to do?
Yeah, well that's what I was trying to show before. I routinely, I no longer hold the anti-PD-1. So I would say that I started doing this about 6, 7 years ago, no, probably 6 years ago now routinely. Before that, we would hold it. But now it clearly doesn't matter. And since then, it doesn't matter at all, actually. Yeah. In fact, it's, the data I was showing, it's probably better.
One of my questions oftentimes is there's so many new targeted therapies available, and that's always a frequently asked question, which I have no data for, like abemaciclib or all sorts of new drugs out there that I don't know. But I've actually just went ahead and just treated it straight ahead without deferring.
Yeah, it's, there are some reviews on this, but the ones that I, and if you have to treat with, omercitinib or an EGFR, it's okay. I mean, I've done it before. The one that you really have to watch out for is pazopanib and axitinib. These second generation anti-VEGF inhibitors that do. There's been case studies of big bleeds from this. So for these, I actually really make sure that they stop. Yeah.
Do we need to worry about the advance of those new drugs that some of which may claim they have better CNS penetration or CNS response, and what's your implication for future when we would like to discuss with our patient? Because there are some guidelines highlighted that maybe the third generation of TKI or some even immunotherapy, maybe in a symptomatic patient, we can hold our treatment.
Oh, that's a great question, and it's something that is ongoing right now. So I'll tell you that with ALK-ROS inhibitors, with those types of lesions, I will routinely, if the lesions are small, I will routinely monitor and not do SRS. Generally, I've seen that the responses with lorlatinib and brigatinib have gotten even better and better. That's the third and fourth generation ones, right? So that's the only case where I will say, okay, go ahead and go on the drug, and then I'll see you back in 3 months, with an MRI. With Tarceva, the previous generation, my experience was that I'd never really trusted it. I actually, if it's larger than probably 0.5 cm, 1 cm, we'll go ahead and treat it. If it's smaller, then what we did was routinely just give 1 month, of drug, and then just look. Now with omercitinib, it really does penetrate the brain better, right? So I will, it's somewhere in between, right? Depending on size. If it's big, it's really big, it almost never completely goes away, in my experience. I don't know what you've seen, but if it's small, it can go away. It's a pretty good chance. So in those cases, we'll probably do an MRI in about 4 to 6 weeks.
Yeah, no, same here. I think I mentioned at the end of my talk, a gentleman asked me about the issues with systemic therapy, and I think you know, for in addition, like plus the molecular markers and the targeted therapies is the histology. You know, like the melanoma data is probably a little more convincing in some ways, or some actually in some ways not. And then for the lungs, I think the also depends on the molecular phenotype of the lung cancers. I think for breast, I know folks have been trying to push for, but I haven't really quite seen as much evidence that it's as successful with targeted therapies versus melanomas and some more PO and high expressing non-small cell lung adenocarcinomas. So I kind of favor being more aggressive with pushing for radiosurgery for those patients. But yeah, for melanomas, I mean, frankly, it's fine. Yeah, great question. Okay, thanks everybody. Yeah.